Okay, great. Thanks very much for that, Carrie. And I'm going to try and keep to time. You'll be wanting your cup of tea before too long. So just to say also what a great privilege it is to be here. Julian was a big influence on so many of us. And although I only met Julian 2 or 3 times, he had a huge impact on me. And Carrie mentioned empathy. Julian was a hugely empathic person. I also want to acknowledge Graham, who's been a mentor to me and to many of us here, and has produced this fantastic book. And only Graham could get a book which has about 50 contributors, and he gets his name on the front cover of it. But so a big thanks to Graham as well, and it's great to be here. So I can go through these, I think, reasonably quickly because I've got nothing here that's rocket science, and Alison has introduced the bigger picture very clearly. Inequalities in Scotland not getting any better, and in this mix comes multimorbidity. This is the work we published in the Lancet 2012 on about 1.8 million people in Scotland, showing the distribution of multimorbidity by deprivation. The most deprived areas in the dark red and the most affluent in green. So a perfect social patterning of multimorbidity by deprivation, more of it in deprived areas and at a younger age. This is quite an old slide. I think Graham produced this about the inverse care law. Again, Scottish data showing the same increase in inequalities in premature mortality and so on, but the flat distribution of GPs across deprivation deciles in Scotland. The situation in England, it won't be any different. And more recently, Graham and I and others published similar work showing, again, the increase in premature mortality and complex multimorbidity, but this time showing the funding per patient registered, going from most affluent to most deprived, and showing actually less funding per patient in the most deprived areas. The green line showing the increase in consultation rates in those areas. So clearly there's a mismatch here, and that's very much what the inverse care law is about. It's very much what the deep end swimming pool diagram depicts. So I came into this somebody who was very interested in consultations as a GP, what really goes on in the consultation, and people I had people like John Howie as a mentor in this, and nobody had really, although we knew about the inverse care law and what it probably meant, I think nobody had really explored it in depth. What does it actually mean for patients and doctors who consult and when they consult? This isn't rocket science. You know, we did something very obvious with this work. We looked at 3,000 patients. We got patients to fill in questionnaires, half of them in deprived areas and half in affluent areas of the west of Scotland. And we simply looked at access, enablement, and consultation length, and stuff like that. And it was published in the Annals of Family Medicine, 2007, I think this was. So what we found was, as we expected, in the deprived areas, compared with patients in more affluent areas, patients consulted with more problems to discuss. There were more things they wanted to talk about in the consultation. These things were more often complex, a mixture of physical, psychological, and social problems. Yet the consultations were shorter in deprived areas than in affluent, and the patients with these complex problems felt less enabled at the end of the consultation using John Howie's patient enablement instrument, which some of you may remember. We also measured GP stress at the end of every consultation, and the GPs on average were more stressed in the deprived areas than in the affluent. One interesting finding from the same data set is that we looked at the relationship between patient enablement and the patient's perception of the GP's empathy. And we never had a single case of high enablement with low empathy. So you could get, you could have high perceived empathy, but no enablement, because enablement's quite a complex thing. But we never got the opposite. And although it's a kind of obvious thing, I think it's quite important in this age of self-management support, which is what the patient enablement instrument was really tapping into, I think. Then we, being a glutton for punishment, I then went on to do a big study, again, half in affluent and half in deep end practices in Glasgow, where we videoed almost 700 routine consultations. We asked patients to fill in a questionnaire before the consultation about their expectations and the problems they're coming with. We asked them to fill in a questionnaire straight after the consultation, and then we followed them up at a month to measure outcomes. And we managed to get a response rate of 70% at 1 month follow-up, a huge amount of work. I have to acknowledge the input of all the members of the research team who helped achieve that. Perhaps Bridie Fitzpatrick being the key person who's not here today, but Bridie has been the kind of workhorse behind a lot of these studies. What did that show? Well, building on the previous study, we actually found obvious things again. Patients in deprived areas weren't that bothered about shared decision-making. They had much less desire for that than in affluent areas. They actually thought the GPs were less empathic than in the affluent patients. When we videoed those consultations for actual observed behaviour, the interaction, the GPs were less patient-centred using sort of validated measures, both verbally and non-verbally. And the outcomes, the patient-reported outcomes, which was symptom improvement and well-being, were significantly worse at 1 month in the deprived than in the affluent. So, in this study, we again found that GP empathy was very important. This time it was the only thing that predicted better outcomes 1 month after the consultation. The actual observer-rated measures didn't show that relationship. So, from the same data set, we then looked at the patients in the 700 consultations who had multimorbidity. And again, all these papers have been published in Annals of Family Medicine, which is curious, but we're very happy. It's a very good journal. What we found in this, when we divided the patients into those with 2 or more long-term conditions and those with 1 or less, was this. When you look at patients, multimorbid patients in the affluent areas, the affluent practices, compared with the non-multimorbid in those same practices, their consultations were much longer, about 40% longer, 13 minutes versus 9 minutes. Everyone's booked at 10-minute appointments generally, so the multimorbid patients are getting actually a fair bit more time. They perceived the doctors as more empathic than the non-multimorbid patients. The videos showed that the doctors were more patient-centred, and none of these differences were found in the deprived areas. So what's going on? Well, it's pretty obvious, isn't it, that the concentration of unmet need, combined with the inverse care law and the deep end here, and the kind of flow of so many symptoms and problems, it simply means that in the deep end, everyone's treated the same, because everyone's got need, it's busy, and you're fitting people in as quickly as possible. And in the affluent areas, not that everybody's not busy and doctors aren't working hard, they are, but there's clearly more give in the system. They can, without booking longer consultations, they give complex patients longer. And that doesn't happen by causing more GP stress. So, hence the GPs at the deep end. What can you do about it? We had a program funded by the Chief Scientist's Office, and in partnership with a number of researchers and also with the deep end GPs and patients, because we wanted to sort of really look at, could we develop an intervention that could have some impact on these poor outcomes and lack of enablement and so on. So we did this according to MRC complex intervention guidelines. We examined the extent of the problem that in the Lancet paper that I mentioned. We did lots of qualitative work, and we developed and optimized a complex intervention. And then we tested it in a feasibility randomized control trial in which we randomized 8 practices, 4 to get the intervention, 4 basically not to get anything, with 152 patients on an economic analysis. So it's not a definitive trial, but it's a reasonably large phase 2 trial, out of which we published a bunch of papers. Again, none of this was rocket science. We were simply trying experimentally to see if in the deep end, if you gave more resource, could you get everyone to dive a bit below the surface rather than running so fast on the treadmill. And it was a very simple logic model. More time, relational continuity, practitioner support, we thought would lead to better consultations, more enablement, higher empathy, and we thought that should lead to better outcomes because we had already shown that many of these factors were important for outcomes. And the Care Plus consultation, the intervention was a complex one. It was a type of whole system approach where we, at system level, we paid the practices the going rate to give longer consultations. And the practices could use that to employ locums to deal with the other stuff and to give patients, targeted patients with multimobility, a lot longer, not 8 minutes, more like 30 or 40 minutes. And that had been piloted, and it was the GPs who came back to us and said, we need at least 30, 40 minutes. And with continuity. So the patients was then followed up by the same doctor over the course of 12 months. The professionals needed support. We had support meetings. We discussed a structure for a patient-centered approach. We had a care plan. But these meetings were actually also just very important for the GPs to help each other in what was getting really close, very close to patients with very difficult problems. That maybe in a 5 or 10 minute consultation you scratch the surface. This was diving deeper. And for patients, we also provided the GPs with some support around self-management material, mindfulness CDs that they could give to the patients. And we highly recommended the GPs to try to refer patients to community resources. We didn't have link workers at that time, but it was a similar idea. So the first thing, would the GPs take part? Would patients take part? Not much work in very deprived areas in deep end of this type. And the answer was a resounding yes. We signed up practices to take part within about 2 weeks. And the patients were all signed up again very quickly, within a couple of months. At 6 months and 12 months, our follow-up points for data collection, we had close to 90% response rates to the patient questionnaire. And that, again, was a huge amount of work led by the researchers within the team. So it showed that, yes, you can do an RCT, a cluster RCT of a complex intervention in these areas, in the deep end, and you can get gold standard levels of data collection. It wasn't powered to show necessarily any benefit. The main part of a phase 2 trial is to see if it's possible to do the actual randomization and data collection and so on. But actually, we did find some evidence of benefit. Firstly, the doctors did give the patients longer compared with the comparison and the control practices. And the patients were very happy with that, not surprisingly, patient satisfaction with the time. We also found some indication that the perceptions of the GP's empathy with the care measure went up. It wasn't significant, but there's a trend. And also in terms of feeling enabled after that first longer consultation. But we were interested in what happened over time because, on average, the GPs had about 3 Care Plus consultations over the course of 12 months with each patient. And what we found was quite interesting, that in the Care Plus group, going from baseline to follow-up, there was some slight increase in quality of life in the patients, whereas in the control groups, things were getting worse, even within 6 months or a year. These patients had on average 6 long-term conditions. 80% had a mental health problem as well, and living in high areas of deprivation with all the social problems of that. So they weren't worried well by any means. So we were able probably to sort of level out quality of life to prevent it getting worse. And in terms of the outcomes at 12 months, we had everything we measured showed a trend towards being in the right direction and favouring improvement with the intervention group. And for a few of these, such as the quality of life measured in a particular way, area under the curve, it was highly significant. And for one aspect of well-being, again, this was a highly significant improvement. So some evidence that the intervention could be delivered and seemed to work. I think what was most exciting for me is we had the health economists pour all over the data. We measured everything, and it was massively cost-effective. So NICE, the UK government, supports interventions with cost 20,000 or 30,000 per QALY as being likely to be cost-effective. This came out at 13,000. So it's not actually expensive to pay GPs to see patients. And we weren't bringing in new staff. We were just expanding. We were reversing the inverse care law as a type of experiment. So I'm going to conclude now, let you go for your tea. So the inverse care law operates by limiting what practitioners could otherwise do to help the health and well-being of patients whose lives are blighted by deprivation. The high level of unmet need and complex healthcare needs in deprived areas in the face of the inverse care law results in high GP stress, less patient enablement, less patient-centered care and poorer outcomes. The disparity between affluent and poor is most apparent in patients with multimorbidity. And reversing the inverse care law experimentally by giving more time, better continuity, and more empathic patient-centered care leads to better outcomes and is cost-effective. Thank you. Have a great conference.